Happy Sabbath. The place looks, seems. Happy Sabbath. Happy Thanksgiving. Okay. My name is Prince Ochiri, Dr. Ochiri. This is Healthline. 2 weeks ago, we talked about what is cardio-oncology. What is, the care of the heart care of a cancer patient. And from there, we are going to talk about some questions that came up. If I may do just a 1 to 2 minutes review of everything that we said, very brief, is that cancer care has advanced so much. However, some of the things we are using, the chemotherapy, the radiation, the immune therapy can have consequences on the heart. It is important to know as a patient because you need to advocate for your health as well. Some can cause issues during the treatment. Some can cause issues right after the treatment. And so you and your doctor, your oncologist, and a cardiologist who knows about this should be involved in the planning of your treatment. And so this is just a brief summary. This is questions that came after. So the first question that came is that, do patients with heart damage from chemotherapy have to switch to a different drug, or is the dose adjusted? This is a very good question, but it's a very complex question as well. So what we are doing is a multidisciplinary approach. For the question is, do we need to switch treatments? A lot of times we should switch treatments. If the first line treatment is causing issues, then sometimes we will advocate for a second line treatment. However, let's say the first line treatment has a cancer cure rate of, let's say, 95%. But then the second line treatment has a cancer cure rate of 30% or 40%, because basically there's a big gap between how the first line works and the second line works. Then it's like you have to really think about, if I stop and go to the second line, will I actually be helping with the patient? Because now the heart will be okay, but the cancer will be rapidly progressing. So it's not a yes or no answer. This is a situation where we say, let's sit down and let's talk about the situation. And the second is, can you adjust the dose? That is also a strategy that sometimes we use. In the case where we say the second line is really, really not a good option, even though it's the second line, and if we let the cancer spread, that's really going to, sometimes we will have to adjust the dose and see whether we can minimize the side effect. So in this case, you are between a rock and a hard, how do you say that? A rock and a hard place? And you don't have a best approach. What you are trying to do is really minimize how much problems you are causing while doing the most good. The other, I think I made a mistake. I'm going to the same one already. So let me go. Is this the second one? Is there a known mechanism as to why certain drugs cause heart damage? Yes. We do know why this happens. Some of them we don't know. But every chemo is not the same, doesn't work the same. Every chemo works differently. And so the mechanisms are different. So let's say we have a medication. One of the medications that is really being used right now is what we call immunotherapy. That medication has really been helpful because it actually attacks the cancer cells in a way that is very, very good, and patients are now having a lot of good cure rates. But that same medication using your own immune cells to attack the cancer cells can sometimes also attack your own tissues. For example, a medication like Keytruda or other medications like that can attack your colon, can cause colitis, can attack the the lungs can cause what we call pneumonitis, can attack the heart, cause myocarditis. It's a rare, it doesn't happen all the time, but it can happen. So we do know it, that it can cause issues, but sometimes we the benefit for using it becomes better than the risk, and so we allow it to be treated. The next question is, I don't want you, if somebody can advance it for me. Are there specialists that need to be involved in the care of patients receiving chemotherapy? Yes. Yes. Like I said, there are places that are blessed to have people like what we call cardio-oncologists, which I am one of them, that have places like that, where we sit down with the oncologist, with sometimes with the radiation oncologist, with the patient, and be able to have let's think together about this. You are informed, you know you make the decision. We give you all the information, and then you make the decision. There are some places that don't have the privilege to have somebody, and sometimes it's going to be an oncologist working by themselves and a cardiologist making them by themselves. And sometimes because there isn't a good overlap between those two, because this one is doing cardiology, this one is doing oncology, and each doesn't really know what they are doing very well. Each other is doing. Sometimes it becomes the patient is not at the center. It's like, well, we want to save the heart. Well, we want to treat the cancer. So if possible, you want a team approach in taking care of this, and a multidisciplinary approach in taking care of this patient. I think the last question. Can you advance the slide? Or what attracted you to the field? What attracted me to the field is a couple of things. I trained in MD Anderson for my undergrad, and I became interested for molecular genetics. But I was also interested in the heart, and I was trying to see, wow, like in certain populations, heart disease is common. And then in cancer patients, it's also common. And I also realized that one time I saw a patient when I was in my residency in Kettering Health, a patient that was admitted to the ICU had heart failure. And the heart failure was caused by a chemo drug. And then the oncologist was like, oh, we need to come to the hospital and give more chemo. And at that time, I had already been interested in this a little bit. And I was like, no, this is not the best time. We need to rehabilitate the heart, because guess what? Heart muscles, you don't get it back. If you have damage to the heart muscle, you don't get back. Okay, there's something called G0 state. You can have, your heart squeeze can improve, but at the molecular level, you don't get new heart cells. Nobody makes new heart cells. And so as much as you can prevent damage, you want to prevent. So this patient, me and my attending was able to say, let's hold off, let's treat the heart, let's get him into the best shape. And then the patient was able to continue this treatment. And so I'm like, wow, there's a population of patients that really need this help, and where we are not treating in silos, but we are treating together. And physicians are working actually as a group, and not trying to advance our goal for the patient, but how should we treat this patient with the patient in mind? Thank you so much for the opportunity, and next time we will have another topic for Healthline. Thank you.